The NCCN has helpful guidelines for management of tumor lysis syndrome. Just as a reminder, TLS is manifested by the laboratory abnormalities of hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia, which can lead to clinical symptoms like renal dysfunction or cardiac arrhythmias. I mentioned earlier that there are certain risk factors for TLS, including the tumor type. Burkitt lymphoma might be the classic example. The bulk of disease, including the size of the lymph nodes or the elevation of the white blood cell count or lymphocyte count, pre-existing comorbidities, for example, renal dysfunction or renal involvement by tumor, or hyperuricemia, which may be unrelated or occurring prior to even the start of therapy. Once TLS occurs, we really need to think about how this event can be managed appropriately. Of course, appropriate prophylaxis with uric acid lowering agents or with IV fluids and monitoring is the best therapy, the best measure to prevent this from occurring. But should it occur, you really need to deal with the individual abnormalities. Mainstays of therapy, as per the NCCN, include very rigorous hydration, additional management strategies for hyperuricemia, for example, increasing the dose of allopurinol or providing uric acid lowering agents like recombinant uric oxidase, more frequent monitoring of electrolytes so that you can prevent or identify whether a laboratory event is becoming a clinical event. And then, of course, potentially changing the acuity of observation. So from home to outpatient or outpatient to inpatient or inpatient to an ICU. And then, of course, involving appropriate specialists as needed, for example, colleagues from the cardiovascular division if there's an arrhythmia or very high electrolyte disturbances, or colleagues from the renal medicine service if there's a concern for the need for hemodialysis or if aggressive measures are needed for managing electrolyte abnormalities. So this is all very nicely summarized by the NCCN and can be helpful for managing patients with acute leukemias or non-Hodgkin lymphomas.
Risk stratification plays an extremely important role in the management and prevention of tumor lysis syndrome. For those patients who are deemed a low-risk population, and again, low tumor burden, low degree of proliferation, and using agents which are not really highly cytotoxic, those are more easily managed with maybe just hydration and close observation alone. The patients who are at intermediate and high risk, those are the patients where you're going to need more aggressive treatment and preventive measures, such as the use of allopurinol, respiricase, and aggressive hydration. And depending upon the risk stratification is how often they need to be monitored and in what setting do they need to be monitored.